All right, ladies and gentlemen, we're going to start our next session now. I'm happy to welcome Dr. Frederick Hagemeister once again. He's going to be talking about diffuse large B-cell lymphoma. So, Dr. Hagemeister.
Okay. Again. Okay, so I had a number of things to choose from about updates, but we talked earlier today about prognostic factors, and I want to talk and spend the time on mostly bispecific antibodies because I think that's where we are very significantly going to go. Next slide. So this is the scope of the problem for relapsed lymphoma, large cell lymphoma. There has always been talk about, oh, the patient had a late relapse from their large cell lymphoma, so we can just give them R-CHOP again because they got a CR with R-CHOP, right? So that's not true. This is a study that looked at a number of patients, 262 patients. We actually had a poster also at ASH. This was at ASH as an oral. And I picked this because it was more patients, and they came up with, I think, better conclusions. The disease-specific survival with R-CHOP only, no transplant was done for these people who relapsed more than 2 years from their diagnosis. That is considered, quote, late relapse. But if you look on the right-hand side, these patients, those patients who relapsed 2 to 5 years are the blue curve as far as PFS is concerned. That's not good. That's terrible, in fact. And that is 2 to 5. That is 2 to 5 years. That's still really an early relapse, isn't it? Really. And if it's more than 5 years, that's the red curve. So about 40% may be cured with second-line R-CHOP therapy. So I'm beginning to think, golly, getting R-CHOP as second-line therapy, it doesn't matter when you relapse, whether you have refractory disease or you relapse late, quote-unquote late. Yes, you can get complete remissions. There's no question the overall response rate in this particular study was 72%, and the CR rate was 57%, less than you might expect their first time around. But it's okay to give R-CHOP, but I don't think you're through with therapy if you give R-CHOP. If you haven't achieved a response, well, you got to go on with something else, and you know what that is. It's going to be CAR-T or something because they're going to have disease that's refractory. Next slide. These are novel agents that have been approved recently by the FDA for treatment of relapsed or refractory large B-cell lymphoma, and there's something that you can administer without a problem getting them. However, they are not approved, FDA approved, for second-line therapy of diffuse large cell lymphoma. They're approved for third or subsequent therapies. Polo-BR, the CR rate was only 40%. Keep that in mind. I don't like BR. It was done for transplant-ineligible patients. Tafasitamab-len, same thing, 40% CR rate, overall response a little higher. But look at the and loncastuximab tesirine, one of the three that I think had the worst patients in it. There were a lot of patients who were refractory, who had high-risk features at the time of recurrence of their disease. So I'm not surprised that the CR rate was lower. But look at the progression-free survivals. These are dismal median progression-free survivals. They're less than a year. And with selinexor, which I'm not even going to talk about, the CR rate was only 10%. And so it's a problem, I think, in accepting these drugs as being what we would consider a standard of care or good therapy for patients who have relapsed large cell lymphoma. I don't have a problem administering it to people who are sort of a little more frail and that kind of thing, but I always worry about them. I've got a lot of problems in using these particular medications, especially, these are the trials. The real world studies results are even worse because they've got refractory patients in them. Thank you. So one of the things we thought is the BTK inhibitors were not going to be very useful in large cell lymphoma. Well, this is zanubrutinib, which is a BTK inhibitor, covalent. This is non-covalent, covalent-bound BTK inhibitor, plus lenalidomide. For refractory or relapsed large B-cell lymphoma. And the response was a little bit different. The overall response was higher for ABC, but CR rates were similar for ABC and GCB types. And these were patients who were ineligible for an autologous stem cell transplant, and 42% of whom had refractory disease. So these were higher risk patients, but it's relatively impressive that these two medications given together, which are not chemotherapy, one of the things I'm kind of focusing on, I'm trying to focus on for you today, as well as the things that we are trying to focus on at MD Anderson. And the median was only 2 prior treatments, but nonetheless, this is a very decent progression-free survival, similar to what you saw before and probably better tolerated than Pola-BR. So you know CAR-Ts. The CAR-T results in general for these 3 studies demonstrated much better results than we expected to see in those patients who had relapsed disease. All 3 agents are FDA approved for 3rd-line treatment of diffuse large B-cell lymphoma, not second. They are different in the patient populations. They are different in bridging therapies, but nonetheless, the progression-free survivals look very, very similar. And I would have to say that giving these, you would expect to get kind of the same results. I think cross comparisons are really impossible. More importantly, this is 2nd-line randomized CAR-Ts versus standard of care for relapsed or refractory large cell lymphoma. And the progression-free survival for axi-cel was significantly better than standard of care, making it better treatment for these patients who have relapsed for large cell lymphoma, refractory or relapsed patients. In addition, the overall survival was also better, despite the fact that 57% of those patients who relapsed after autologous stem cell transplant then got a CAR. So CAR was better to give before the autologous stem cell transplant rather than after. In the TRANSFORM study, the curve at the bottom on the left shows those patients who were considered to have refractory disease compared to standard of care therapy, which was an autologous stem cell transplant. And on the right-hand side, significantly better results for those who had relapsed disease rather than refractory disease, but better than standard of care. So the problem with CAR-T, of course, is that it is a, quote, designer therapy, in essence, with limited access due to cost and resource requirements, and there are high toxicity, precludes treatment in patients with comorbidities, although more patients can get CAR-T than can get stem cell transplants. Patients with poorly controlled disease may not benefit because they may not be able to wait the 2 or 3 weeks it takes to manufacture these, and most patients will relapse despite treatment with CAR-T cells. So let's talk about bispecifics. The bispecifics, despite the fact that CAR-Ts had varying kind of patients, the bispecific studies, all 4 that I'm going to show you, I won't show you much about odronextamab, but the 4 bispecifics, mosunetuzumab, glofitamab, odronextamab, and epcoritamab, they all had basically the same kind of patients enrolled. And the way that the studies were conducted were very similar, as I'll show you on this next slide. However, dosing is really very different, and you have to look at them carefully when you look at the package insert or how the drugs are administered when you decide to talk to the patient about how they're going to receive these medications. For example, glofitamab, which is the second one here, you give obinutuzumab. It is the only one of these that in which you have to give a CD20 antibody, naked CD20 antibody before to mitigate CRS. I'm not sure that the dose is right, but everybody knows you give 1,000 milligrams of obinutuzumab, so they chose 1,000 milligrams. It was 2,000 in one trial, but it's 1,000 milligrams. The red boxes show you when you're going to get your full dose of therapy. And notice that with mosunetuzumab, whether it is given intravenously or subcutaneous, you achieve your full dose within the first cycle. However, with glofitamab and odronextamab, you don't get full dose therapy until your second cycle of therapy has been administered. When you then give epcoritamab, you go back and you receive your full dose. They all require step-up dosing, is one of the common things. And then there's this, how long do you treat them, which is the green box. I got the purple box a little bit with odronextamab because the dose is actually escalated during maintenance, which is kind of weird. You've already achieved a remission, and now you're getting maintenance at a higher dose. However, the others are all different as well. You actually reduce the dose in maintenance with mosunetuzumab. Keep the same dose if it's when it's given IV. When it's given subcutaneous, you give the same dose for a year. But glofitamab, it's shorter than a year. It's only 12 doses with a dose every 3 weeks. And then maintenance therapy is given odronextamab and epcoritamab until the patient progresses. So these are all different ways that they are administered, and the dosing administration, which is important to monitor and watch. These are the results for glofitamab, epcoritamab, and odronextamab. I'm not including mosunetuzumab because it is not one of those that was really being considered for large cell lymphoma. It is approved for instead follicular lymphoma. The reasons for the specific bispecific antibody features are shown here. The age, there was no upper age or 75. The pathologies are shown here are very similar. Step-up dosing was necessary with all of them. All of them included patients who had CAR-Ts or autologous stem cell transplant. They almost have no CRS or ICANS of significance. They all evaluated refractory or relapse status, and they collected end of treatment MRD status, which I like because I think that's going to be something important down the road. And they all show significant benefit from that standpoint. The PFS looks very, very similar for glofitamab as well as the epcoritamab, considering CRs and PRs are almost identical. The PRs are higher, of course, with glofitamab, but it's comparing apples and oranges, perhaps. This is what happens after you get a CAR-T and then you develop a relapse. Only patients who actually receive a bispecific antibody have a significantly better or longer progression-free survival or survival compared to anti-PD-1, other chemotherapy, lenalidomide, or other targeted agents. This is an analysis of adverse features influencing outcomes of bispecific antibodies post-CAR-T. It depended upon whether the patient had sensitivity to treatment prior, that they have a CR or not. The earlier relapsed or refractory disease was worse. Additional therapies between CAR-T and bispecific antibody were also made the patients worse, and having a relapse within 6 months since lymphodepletion before CAR-T or bendamustine, which is a dangerous drug to administer to a patient with large cell lymphoma whom you're planning on giving CAR-T to, or apparently glofitamab or other bispecifics. There's another study also that was reported at ASH that if it was less than 90 days from CAR-T to relapse, it's very unfavorable compared to relapse more than 180 days. This is an interesting study that looked just at single agent epcoritamab for patients over the age of 75 with untreated large B-cell lymphoma who are anthracycline ineligible. One of not only the CR rates, but also the progression-free survivals and overall survivals are relatively impressive for this drug that is given subcutaneously for these older patients. But what's more interesting about this study is they actually described for the first time for me what anthracycline ineligible patients really are. I don't see that in many of the patients that I've reviewed or looked at or thought at. Many of the studies just say they were not eligible for anthracyclines but don't give a description. This does. Let's talk about combination therapy. This is glofitamab plus rice for relapsed or refractory diffuse large B-cell lymphoma that was also presented at ASH. The glofitamab was administered exactly as you would expect with the step-up dosing and receiving your full dose of 30 milligrams on cycle 2, and rice was given just before it. Notice that the impressive rate of overall response of 83.3% on the right-hand side with a CR rate of 66.7. Remember rice that was administered in a randomized study to RDAP for patients who were going for transplant in Europe, where this overall response rate was 50%. This is significantly better and looks much better than does that particular report. In addition, if they happen to be primary refractory, there were 31% of the patients, but a number of them were relapsed at study entry. But nonetheless, it didn't matter very much. The patients who were primary refractory, there were only 13 patients, but the CR rate was 53.8%. If they had relapsed, it was in the range of 70%. It doesn't matter how long it was from the relapse. So this is a really nice trial and a nice study to be able to consider for those patients who would ultimately maybe go for a stem cell transplant. But it is not FDA approved as yet for second-line therapy. More impressive was this randomized study of Glofit Gemox versus R-Gemox for relapsed or refractory LBCL ineligible for stem cell transplant. This is also an important study in that the primary endpoint was not progression-free survival, it was not CR, it was not duration of response, it was overall survival. I don't recall having seen a trial, a randomized study, in which overall survival was the primary endpoint. That's impressive. It means you have to have a lot of courage and a lot of strength to be able to decide to make that study have a primary overall survival endpoint. And they were right. The overall survival was significantly better for patients who received Glofit Gemox if they were ineligible for a stem cell transplant. Not only from the standpoint of overall survival, but you can see that it is going to be FDA approved, more than likely, as second-line therapy in June 2025, this coming June. This is glofitamab polatuzumab. I like this regimen. This is really pretty good for patients who are older, in fact, and are not going to be able to tolerate chemotherapy because there is no chemotherapy in this regimen. These are for patients who have had at least one prior therapy. And you can see that across the board on the left-hand side, lower part of the slide, it didn't matter whether you had diffuse large B-cell lymphoma, high-grade, transformed follicular, primary mediastinal, there were only 2 patients, or prior CAR T. Still, CR rates were very, very impressive. On the right-hand side, that's a waterfall plot, and you're accustomed to seeing responses or tumor response and that kind of thing. But this is end of treatment ctDNA log fold change by histology. And you can see that all histologies had a drop in their ctDNA, and progression-free survivals were very similar. Patients who had CRs did better. I'm not showing you that slide. This is a follow-up of Polarix, polatuzumab R-CHOP versus R-CHOP, and you can see that with longer follow-up, the progression-free survival still remains significantly in favor of Pola R-CHOP. And as was discussed at the presentation at ASH, it's really, they already had described that ABC subtypes did better as opposed to GCB that didn't show curves. But what's more important, I think, in this particular presentation is that fewer subsequent therapies were required for the Pola R-CHOP. Those are the green boxes, and the different kinds of therapies they received are shown there. In the blue boxes are those who got R-CHOP. And the cumulative index of cause of death, including a number of patients, about 200, who came from those who were treated in China, is shown here. Next slide. That all deaths are included in these curves, but the next, this shows you the non-Hodgkin lymphoma deaths and then the not non-Hodgkin lymphoma deaths. They're about equal. So we need to start looking at overall survival from the tumor as opposed to other causes in not only large cell lymphomas, but also follicular lymphomas and mantle cell lymphomas as well. This is epcoritamab plus R-CHOP as frontline therapy for patients with large cell lymphoma and an IPI of 3 or greater. These are considered high-risk patients because their IPI is high. Look at that PFS. Look at the CR rates. Look at the overall survivals. The 2 overall survival curves that I'm showing you are for those who happen to have overall, the whole study, 47 patients, but also the double hit and triple hit patient. This is not R-CHOP, this is epcoritamab R-CHOP. Could this be a solution for our problem about giving dose-adjusted EPOCH-R or more intensive therapy? Could we get the same results in those patients who have dark zone lymphomas? And then this one, which this one is such a good study. I had to include it. This is Glofit and unipolar R-CHP versus R-CHOP. This is Glofit Pola R-CHOP versus Glofit R-CHOP, no Pola. Randomized study for untreated high-risk diffuse large B-cell lymphomas. IPIs of various kinds were included, GCB and ABC subtype. For complete response rate didn't matter. It's nearly 100%. The PFS by study arm didn't matter. You didn't have to give Pola in order to be able to achieve these results, as long as you gave Glofit. In addition, this PET scan negativity, this was actually patients who were in metabolic PR, or the gray boxes, and with further follow-up and no additional therapy, those patients who were in metabolic PR went into metabolic CR with no further therapy and just watching them. You've always suspected that could happen in some of your patients who had a good response and a PR. It's true when you give glofitamab in addition, because you've still got something working. We have a fellowship program. I'm obligated to show that particular slide. It's a lymphoma fellowship program that goes on for a year with an option for 2 years. Our first 2 years fellow is currently going through that rotation. We also have, it includes inpatient service as well as learning about CAR-Ts. Thank you very much for your attention.
Thank you, Dr. Hagemeister, for another wonderful talk, and welcoming back Dr. Jain, who will be speaking to us now about advances in CLL. Thank you.
Give me the adventure slides. Give me the adventure slides.
All right. Good morning again. So, in the second this talk, I want to talk about advances in CLL, and we'll skip the CAR-T advances in CLL because I already covered that. We'll talk about BTK inhibitors and some data with BTK degraders, which is coming along in the context of CLL. Disclosure. So, just as a brief background, this is a recent review article where we wrote, and this figure shows different target therapies which have come along for patients with CLL. We have BTK inhibitors. Now there are 4 different approved: ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib. We have one BCL2 antagonist, venetoclax, approved, but there are a couple of others in phase 3 studies, namely sonrotoclax and lisafdaclax. We have CD19 CAR-T approved. We have PI3 kinase inhibitors approved, but they are not used much these days. And then we also have obinutuzumab, as well as obviously rituximab, for use for these patients. In the field of CLL, a lot of emphasis has been now these days of combining these therapies to get the maximum benefit out of it and to make them into time-limited approaches. Also want to briefly show you that it was just about 10 years ago, now coming up to 11 years ago, that ibrutinib was approved for CLL. So we are 1 decade into this targeted therapy era in the context of CLL. And this has really revolutionized. Ibrutinib was the first one, but obviously now we have many other agents, how we manage patients, and chemotherapy has been completely abandoned in the context of CLL. And these are the agents, again, listed in terms of approvals. You can see in 2014, as I mentioned, ibrutinib was approved, but now we have several of these agents approved. And if you look at more recently, in 2023, we had zanubrutinib approved, as well as pirtobrutinib approved, 2 BTK inhibitors. In 2024, we had liso-cel approved for CLL. And then 25 and beyond, I guess we are looking at bispecific clinical trials, novel BCL2 inhibitors, novel BTK inhibitors, BTK degraders, or BTK PROTACs, and I will cover some of them in this talk. So first I want to talk about the first-line CLL and talk to you about a very important abstract which was presented at the ASH meeting. So currently, if you're managing patients in the frontline therapy of CLL, we have options of indefinite therapy. You can use ibrutinib all continuously, acalabrutinib with and without obinutuzumab. You can use zanubrutinib. And here the intent will be you give these BTK inhibitors continuously daily. Or you can have a time-limited approach where the approved in the United States is 1 year of ven obinutuzumab based on the CLL14 study. Also 1 year of ven ibrutinib is approved outside of the US in many countries, but not in the US. But the advance I wanted to share with you is the data presented at ASH, which will come out in New England Journal soon, is 1 year of when acalabrutinib with and without obinutuzumab. And again, the approval is expected soon, but maybe in the next few months we'll see. So what is that regimen? Before we go to that regimen, I just want to show you that there's so many of these covalent and non-covalent BTK inhibitors in development. We have BCL2 inhibitors, multiple of them in development. And a lot of what's happening in the clinical trial space, and including the phase 3 randomized study space, is combining them in different fashion to make it time-limited approaches. So a lot of effort is being done combining BTK, BCL2, so 2 oral drugs together, and also in terms of triplets, why don't we use all our best drugs up front, combine a BTK, BCL2, and CD20 antibody. So in this regard, this abstract was presented in an oral presentation at ASH. This is called the Amplify study presented by Jennifer Brown. So this is a study for younger patients with CLL, where the comparator was chemotherapy, and you can argue about the relevance of chemotherapy in the current era, but that was the control arm was. Probably one of the last trials which has used that as a control for their patients. The 2 experimental arms were important, obviously. So the one was AV, which is 1 year of venetoclax plus acalabrutinib. So you start with acalabrutinib first. For 2 months, you're just getting acalabrutinib, and then you add venetoclax, and both drugs continue for 1 year. Or you can have a triplet of AVO, which is you also add 6 months of obinutuzumab. So this trial, will really for the first time give us a doublet versus triplet in a kind of a randomized study, and obviously comparing it to chemoimmunotherapy. This is the overall treatment characteristics. So this is a large trial. Close to 900 patients were enrolled. A lot of these patients were enrolled actually in Europe and outside of North America. And rest of the characteristics were pretty well balanced. And this is the primary endpoint of the study. So the primary endpoint of the study was progression-free survival as assessed by the independent review committee. So the green curve here is the chemotherapy arm, obviously not performing as well as we would expect. The top curve, 83%, is AVO triplet, and then the AV doublet is close by at 76%. So both the arms were superior, statistically superior, to the chemotherapy arm. And I believe based on this, I would expect that both acala-ven 1 year duration and acala-ven obin, also for 1 year duration, may likely should get approved by the FDA. Now, in the context of CLL, if you're managing these patients, one of the very important prognostic markers is IGHV status. If you look at the mutated IGHV, which historically has been shown to be more chemosensitive, you can see mutated IGHV actually do very well with all the 3 kind of regimens, including chemotherapy. But if you look at the unmutated IGHV, you see the separation of the curves. In fact, here, the AVO, the triplet arm, really seems to be doing very well. The doublet of A plus V slightly inferior at about 70%. Still, both were superior to chemoimmunotherapy. Now, one of the things which happened in the study was this occurred in the era of COVID. So unfortunately, there were many COVID deaths, which were largely in the CD20 antibody arm. So there were 10 deaths in the AV arm from COVID, but if you look at the AVO and the FCR-BR, both of which have antibody, the number of deaths were, about 7 to 8%. So there was quite a few COVID deaths, which kind of made the analysis a bit more challenging to see. And they did then remove the COVID deaths by censoring them. And you can see the curves, all the curves slightly improved further. And these are the MRD rates. Dr. Hagemeister mentioned in his talk about MRDs. Interestingly enough, the highest MRD was seen in the triplet, the AVO. The second highest was seen in chemotherapy, and somewhat, surprisingly, the blue bar is the AV triplet of acala-ven. So there was a bit of a surprise that it is not performing as well as we would have thought it would. We thought it would be 50-60% MRD rate, but that was not the case. But still, the PFS curves looks better compared to chemotherapy. And this is the overall survival. Again, because there were more deaths from COVID in the antibody arms, if you look at the left curve, there were the AV arm is better, but if you look censored for COVID, all the 3 arms are doing better. So this trial, will have for the first time in the US a 1-year time-limited approach of 2 oral drugs, namely Acala and Ven, approved, hopefully in the next few months. And I do think that would change prescribing pattern. Right now, we talk about Ven-G for 1 year or continuous BTK inhibitor therapy, but Ven-G can be a bit challenging with infusions and TLS monitoring. But I think this Acala-Ven for 1 year, I think maybe logistically much easier, taking 2 pills for 1 year. Now, you could add obinutuzumab to that as well. I guess then that's a part which we'll have to kind of clarify for which subgroups. This slide just shows you lots of trials are happening in the field of CLL. And the purpose of this slide is that this frontline therapy will continue to evolve. And also important one I want to highlight is that the control arm for all these trials, the new trials, except for maybe 1 or 2, is all non-chemotherapy. So the control arm is now venetoclax, obinutuzumab, or ibrutinib, which makes sense. So I think the next couple of years, some of these randomized trials will read out. The ones I highlighted in yellow are expected to read out at ASH, but we'll see. And I think they are also very important in the field in terms of knowing further about these doublet combinations. Also, I want to highlight is that besides venetoclax, there are other drugs coming along, like sonrotoclax. And this was also at the ASH meeting, that if you combine sonrotoclax with zanubrutinib, so 2 oral drugs together, very high rates of MRD were achieved for these patients as well. So again, I think, at the end of the day, we'll have to do some randomized studies too, because all these studies are looking very, very promising in terms of rates of MRD, in terms of the PFS. This is work from our group, which was presented at ASH as well, where we have used pirtobrutinib in the frontline setting in a triplet regimen. So this is the only triplet pirto-based regimen currently ongoing. This is an investigator-initiated trial at MD Anderson. 1 year of therapy, so time-limited approach. And what we showed here is that these are the very high rates of MRD, both in the blood and marrow. And also, I want to highlight one point, is that we checked MRD by clonoSEQ here, by adaptive. And so these MRD results by clonoSEQ, both in the blood and marrow. And the green bar is clonoSEQ negative at 10 to the minus 6 sensitivity. So these are very high depth of remission patients are achieving, not just at the MRD 10 to the minus 4 sensitivity, but also at the minus 6 sensitivity. Now, I wanted to touch base on 2 different new targets which have been explored in CLL. And one was already mentioned about the bispecific antibody. But I think the real exciting thing which is coming in the CLL in terms of the new drugs is the BTK degraders. So the 2 BTK degraders were presented at ASH, one by Nurix and one by BeiGene. And they're really, so the concept behind these degraders is that instead of inhibiting a BTK protein by binding to a pocket like cysteine 481S, these degraders degrade the complete protein itself. They just basically degrade the complete BTK protein, irrespective of the mutations or anything which may be present there. And these are oral drugs. So the Nurix compound, they had 60 patients enrolled, 4 prior lines of therapy. All patients practically had received prior covalent BTK inhibitors. Most patients had received venetoclax as well. So heavily pretreated patient population. And then interestingly, with these BTK degraders, at least so far, we are not seeing the side effects we associate with BTKs, such as AFib, bleeding, arthralgias. So again, they had 1 patient of AFib here who had prior AFib in this setting, but we're not really seeing those typical AEs we associate with BTK inhibitors. In fact, the most common adverse event was a grade 3 or 4 neutropenia of 20%. And this shows the waterfall plot. Again, the duration of treatment is only 4 months here, so it's early. But as you can see from the green check boxes here, most of the patients are still on the drug, they're deriving benefit. So this looks like a promising strategy, an oral drug. Majority of the patients are responding. So, and BeiGene had a very similar abstract. They were presented back-to-back at the ASH meeting, presented by Megan Thompson. Again, the same concept. Just so happens they also happen to have 60 patients. They also happen to have 4 prior lines of therapy. So it's kind of very, very similar characteristics of patients. They also did not show any atrial fibrillation. There were a couple of patients with some hemorrhage, but not any typical BTK side effects. They also showed very high rates of response. You can see 93%. And this is their waterfall swimmer's plot. And again, as you can see from the arrows, most of the patients are still on the drug. Here, the median duration of treatment was about 10, 11 months. So this is slightly more mature data to say. So both these data sets, and there's one from AbbVie, which is coming along as well. I really think that BTK degraders, if the data in the next 1 or 2 years continues to look the way it is looking, I won't be surprised that these drugs may eventually replace inhibitors in the context of CLL. I think these are pretty impressive data. And bispecific antibodies was mentioned in the previous talk. They're also coming in the context of CLL. This is epcoritamab, small number of patients. They're also showing high rates of remission with MRD negativity, which is great, but the challenge so far has been cytokine release syndrome, which again, they're mitigated by step-up dosing. Again, kind of extrapolating from the lymphoma word to say. So that's another drug class, which I think you'll see more data coming up in this year meeting. My last conclusion slide, I just want to, in the interest of time, I think in the first-line BTK inhibitor therapy, first-line CLL, I think that there will be major uptake of Acala venetoclax in the United States, given when it gets approved. I think BTK monotherapy may go away in the frontline setting, except for patients with del(17p-AP53) or older frail patients. These other combinations, such as Zanus and Rodoclax, Pirto, venetoclax, these are still some years away. Phase 3 trials are underway, but we'll see how they kind of pan out. And the relapsed refractory CLL, I mentioned in my previous talk about data with CAR-T plus ibrutinib. I think we have to move them into early lines of therapy, especially the BTK degraders, as well as bispecific antibodies. And with this, I will conclude right on time. Thank you.
Thank you, Dr. Jain. Really appreciate you staying on time. Fantastic talk. We have time for one quick question and then a break. Any questions from the audience? Something? Don't be shy, guys. You've been quiet all day. Yes, sir, Dr. Hagemeister.
Okay,
Just a comment. We are following your guide in mantle cell lymphoma as well. It looks like the explosion in what's happening in mantle cell lymphoma is exactly what you're experiencing and have been experiencing with BTK degraders,
Right.
as well as combinations of doublets and triplets and all that kind of thing.
Right.
The way with chemotherapy.
So we're working hand in hand with you guys as far as where you're going
Sure. Yeah, that's
in
great.
that
Yeah.
disease.
Thank you very much.